So, welcome to Nursing Pneumonia Chapter 5 YouTube video series. I'm going to start sharing my screen and we're going to talk about, nursing implementation in the ambulatory care setting and much, much more. So, let me share. There you are. So, when it comes time for these people to leave our acute care settings and go into the world and become our ambulatory care patients, there's some different teachings that we need to do. We're going to be needing to teach them about these things. We're going to emphasize the need to take the full course of antibiotics. If the antibiotics are working well, they may want to stop taking them after the third or fourth, maybe fifth day. Perhaps they're having some unintended side effects from their antibiotics, such as diarrhea, fungal and candida yeast infections, either in their mouth or in other areas, because the antibiotics have taken out too much of the biome to regulate the candida. They need to take the full course of antibiotics, because otherwise that's how the superbugs get developed, is because people weren't taking the full course of antibiotics. We got enough superbugs as it is that are resistant to too many antibiotics. We don't need any more. Take the antibiotics. We want to educate them on drug and food interactions. People who are on birth control and they're on an antibiotic, some antibiotics will cancel out birth control. The person taking the antibiotics and the birth control will probably want to know that, because there's probably a reason why they're on birth control. And if the antibiotic is going to interact with that, they should be aware of that. The importance of getting rest, the importance of adequate hydration. We need to keep those secretions thin, so they can be expelled appropriately. And it's very easy to get dehydrated when you're sick. I'm not sick, but hydrate. Avoiding alcohol and smoking. Alcohol and smoking will be interfering with your body a lot. Cool mist humidifiers and warm baths are really helpful. That cool mist humidifier or the warm bath, where you can have that sort of like, it's almost a hydrating effect within that upper airway, which will decrease their cough, which will help make them more comfortable. Dry rooms, dry living environments sometimes exacerbate cough just by their very being. So these humidification efforts, either by warm baths or cool mist humidifiers, will help that patient reduce their cough. They should be aware of any follow-up chest x-rays. They should be aware of any vaccination schedules that they should be a part of. And the other thing is their body has just gone through a major infection process. It may take several weeks or more to recover. So I mentioned this a little bit earlier, but there are multi-drug resistant pathogens. It's a major problem of treatment. This is why we have to have everybody take their full course of antibiotics, because bacteria, for not having any brain, are actually pretty smart. And so what they will do is they will actually exchange information. You know, by the way, be on the lookout for this amoxicillin kit. And then all of a sudden we have amoxicillin resistant drugs. Methicillin resistant Staphylococcus aureus exists because somebody had people, not just one person, people had staph infections that were being treated with methicillin, but they didn't effectively take all of the methicillin. The methicillin was intended to kill off all the Staph aureus, but some of the Staph aureus survived anyway. And then they passed that on. Now Staph aureus, there's a whole strain of Staph aureus that knows how to survive methicillin. And that's why we have methicillin-resistant MRSA, methicillin-resistant Staphylococcus aureus. And that's how it happened. So risk factors for MDR pathogens for people developing a infection with MRSA or BRSA or a VRE, advanced age, immunosuppressants, history of antibiotic use in the past for appropriate reasons. I'm not saying it's inappropriate. Nobody like takes street amoxicillin, but a history of antibiotic use. And then people who are on mechanical ventilation for a prolonged amount of time have an increased likelihood of developing an MDR pathogen based pneumonia. Other complications of pneumonia include atelectasis, which is something you will see in the, it's identified by chest X-ray. And what it is it's a stiffening of that lung tissue. So atelectasis means that you have very stiff lung tissues. And on X-ray, it looks like ground glass opacities. So it looks like clear sand in a lot of ways on a chest X-ray instead of looking like nice and open. Pleurisy is another side effect of a complication of pneumonia. Pleural effusion, where there's actually a buildup of fluid between the chest wall and the lung itself. And that pleura is over top the lung tissue, and there's the chest wall, right? And then so in between there, you can get a fluid buildup. Bacteremia, where bacteria enters the bloodstream. Pneumothorax, where there's a collapsed lung. Acute respiratory failure, where the lungs have just been working so hard for so long that they can't do it anymore and they just give up. Sepsis and septic shock. I had mentioned this in another slide, but pneumonia can very easily lead to sepsis and septic shock, as well as having a lung abscess, which is a gathering of pussy fluids on your lung, and then empyema. There's a variety of different vocabulary words that are associated with complications of pneumonia. So these vocabulary words, I've been giving you for some of these, I've been giving you my my own like personal definitions, but you should be able to, because these are going to be written up in H&P notes. So you should be able to recognize them and have a decent idea about what it is that they mean. The diagnostic studies that are associated with, just so that you're aware, these are the diagnostic studies that are associated with pneumonia, and this is what MD orders will be coming through. So you'll have that H&P that I had mentioned on the previous slide. They can order chest X-rays, where it's just a simple X-ray picture. Thoracentesis or bronchoscopy, where they actually take a scope and they either go through the bronchioles and they take a look and see how the bronchial tubules are open. Thoracentesis is where they use a very long needle. Like maybe there's a pleural effusion, right? And they use a very long needle and they'll draw that fluid off through that long needle out from between the chest wall and the lungs, and then draw it off so then the lungs have more breathing or more room to move. Pulse oximetry is an order that we can get. ABGs are orders that we can get. Drawing an ABG is usually out of the scope of a normal RN without advanced training, just to let you know. Sputum gram stains, culture and sensitivities, ideally before those antibiotics are started, because we don't want to, we want to know for sure what it is that we're going after. So we'll be getting those sputum cultures before we start the antibiotics, ideally. Now, if you have the antibiotic piggyback in hand and you have a sputum cup in the other and they cough a loogie and you can catch the loogie and the antibiotic, it can really just happen that fast. Blood cultures are also ideally drawn before the antibiotics are started, and a complete blood count with differential will help the doc determine what it is that it can help the docs determine what the client is fighting by looking at what sort of agents are out there fighting the disease process. Interprofessional care on page 27.5, We're trying to do our best to prevent streptococcus pneumonia, and we're doing that through pneumococcal vaccines like Prevnar and Pneumovax 23. We'll also be implementing prompt treatment with antibiotics. The nice part about antibiotics is when we do it right, and if we've got the right one, response will generally occur within 48 to 72 hours. And their temperature will drop, their breathing will improve, and they'll have decreased chest discomfort. We also may want to have a repeat chest x-ray in 6 to 8 weeks, see if there's any long-term damage from those lungs having all the infective process. Supportive care, oxygen for hypoxemia, whether it be nasal cannula, non-rebreather, sometimes BiPAP, CPAP. We're going to be working with respiratory therapy to be able to determine best course of action for oxygen delivery for that hypoxemia. We can give some analgesics for the chest pain. That chest pain is the pleural chest pain, the rib cage pain. If your client starts complaining of chest pain, please don't if it's new and different chest pain, let's be sure that we're not having some cardiac problems. Antipyretics for fever, so adjuvant drugs, any sort of drugs that will help increase their rest and activity, increase their comfort levels. Perhaps they're having a little bit of diarrhea from the antibiotics, so we may have some Imodium or something else that will help with the diarrhea that might be associated with their antibiotic therapy. And then individualize their rest and activity. We're going to be clustering care for these people. So we don't go in once every 5 minutes with one little task to do. We're going to gather ourselves, we're going to gather our supplies, and we're going to go in once every hour or two. Be able to get everything done that we need to get done with that client for the next hour or two so they can have some rest and be able to recuperate. If we have a viral pneumonia situation, there is no definitive treatment other than supportive care. There can be some antivirals depending upon what's going on. There may not be, depending upon what sort of virus you're dealing with. So when we have a viral pneumonia, we're definitely doing supportive care, but we may not have some sort of antiviral that will help out the client. And then for community-acquired pneumonia and drug therapy, this is table 20.7.6. This is that slide 33 that I alluded to earlier. So we are going to be doing some initial empiric therapies, gram-negative and gram-positive organisms. We're going to be doing our best to be, thank you, microbiology lesson. Pneumonia really loves, you'll use a lot of your microbiology class in your pneumonia clients or working with your pneumonia clients. So what we're ideally doing is going after the most likely infective organism and determining any risk factors for multiple drug-resistant organisms. It does vary between local and institutional prevalence and resistance patterns. So not only are we looking at the individual when we're looking at this, but we're also looking at the public health trends and seeing what Olmsted County is reporting, or whichever county it is that you are practicing in. Ideally, when you've got some empiric or some antibiotic therapy, they should be seeing improvement in 3 to 5 days, or they need to come in and be reevaluated. And then normally what happens is we start with, and the super sick people in the hospital, we'll start them IV and proceed to oral when we're stable before they even discharge. In ambulatory care setting, we'll have them start with oral. The rules are you need to be having antibiotic therapy of some sort for at least 5 days and without fever for 48 to 72 hours, depending upon what you have going on and what your doc's comfort level is and the patient's history. As far as nutritional therapy, we are going to be making sure, again, that they have adequate hydration. We'll be monitoring their intake. That adequate hydration thins and loosens the secretions, makes them easier to get out. We do adjust hydration for older adults, especially those patients with heart failure, because their heart's having a hard enough time moving stuff around anyway. And then for those with pre-existing respiratory conditions. So we might be tweaking this just a little bit to make sure, like there is such a thing. Too much of a good thing can be a good thing, or can be a bad thing. And in terms of hydration with certain patients, that is the case with some. Small, frequent, high-calorie nutritional meals, we want to monitor their weight to make sure that they're not losing weight because of their pneumonia status. When it comes to pneumonia and nutrition, the client would rather breathe than eat, so they will pick breathing over eating all the time. If we can make eating easy with small, frequent, high-calorie, nutritious meals, even if it's ensure shakes and milkshakes, it's better than not eating at all. So if we can get them, if they can just go into like grazing mode where we're getting them nutritious stuff, that's better than anything else that we could do. So I'm going to stop sharing. This chapter 5 was a little bit lengthy. I apologize. It's a little, but it all kind of clumped together really nicely. So as always, this has been Pneumonia. Please reach out to me. If you have questions, bring them to class, email me. Let me know how it is that I can help you better understand things. This was all developed from your Lewis textbook, and we will see you when we see you.